That's an interesting topic, a whole nother topic in and of itself, because the way we use the robot, it's not actually independent. It's controlled by a surgeon. So it's really just a different tool, I think, is the best way to honestly consider it. I think that your point, though, about how we train, and of course that's a big part of my job, is training the next generation of surgeons. And it's a concern across the United States and even across the world about whether the next generation of surgeons are going to have the capacity to do surgery in different ways. You know, the robot, as an example, the robot's a great device, but it's just really a tool. And what happens if somebody who only knows how to do things with a robot assistance has a problem? The device fails or something like this. What's our safety backup? And how do we make sure we have reliability within the healthcare system to address those issues? It's not just unique to healthcare. The airline industry and other high reliability industries have these same challenges. And so those of us who are charged with thinking about the optimal ways to train and educate people put quite a bit of thought into that. And we try to give our younger surgeons, our trainees, a broad experience, so that they're comfortable with multiple approaches. I will say, though, that it is another aspect of the way healthcare is evolving that is leading more and more to regionalization, because you just don't have surgeons in the smaller hospitals who have the volume of things like I do to adequately be able to take care of those patients. It is actually. It is a challenge. We're using more simulation to be able to address some of those issues. And here, right after, well, 10 years ago, after Hurricane Katrina, that was one of the initial initiatives of the surgery department when I took over this role, was to make a simulation center that could address some of those issues. And we're broadening it out to include even things like physical diagnosis for patients who might present with symptoms that aren't terribly common. So we use simulations, standardized patients, and we have actually pretty specific protocols, educational protocols, and evaluation techniques to help with those issues. But they're very real. I think actually there's a lot more to be done, and the technology is really amazing. And the way we look at minimizing trauma from surgery, helping the body to heal, optimize the results are incredible. I'll give you just an example with the pancreas surgery. So one of the surgeries we do for pancreas cancer sometimes, it's a very big surgery called a Whipple procedure, where we remove part of the small intestine and part of the pancreas, about half of it, all of the bile duct, and then have to reconstruct everything together. Well, 20 years ago, 15, 20 years ago, that surgery would typically take 8 to 10 hours. The average blood transfusions would be 6 to 8 pints of blood for that surgery. Here at Tulane, with some of the modern devices and techniques we have, we only use a blood transfusion in about 20%. So 1 out of 5 patients gets a blood transfusion, and usually that's 1 or 2 units of blood. And normally those patients come in a little bit anemic to begin with. So just in that period of time, 10, 15 years, we've transitioned from a surgery that took 8 hours to a surgery that takes 3 to 4 hours, and a surgery that usually required 8 units of blood to one that most of the patients don't even get a blood transfusion anymore. And that's really, so much of that has to do with technology. Some of it also has to do with regionalization, because those of us that are doing those surgeries in general are doing more of them. And of course, as you get more familiar with anything, hopefully you do a little bit better.